Hello, my name's Colin Cooper. I'm one of the physician assistants on staff here at the Bryn Mawr Division of Academic Urology. We put this video together to give you more information to help prepare you for your upcoming procedure. When you scheduled your surgery, you should have been given this document. It's titled Preoperative Instructions for Patients Undergoing Robotic Prostatectomy. If for some reason you don't have this packet, it's no problem. Call our office and we'd be happy to dispense one for you. It probably makes sense if you've had a chance to read through this once or twice prior to watching this video. And certainly you'll want to have it close by so you can refer to it as I go through. I'll take it one page at a time, so let's get started. If you take a look at the first page, that details the instructions on what you need to do for preoperative testing. When you scheduled your surgery with our surgical coordinator, she should have arranged all these appointments for you and told you what you needed to do. If you're not sure who you need to see or when, be in contact with our surgical coordinator and she can help guide you. Next, we're going to focus on the second page. It's titled 10 to 14 days prior to surgery. The top portion of the page gives you detailed instructions on medications that you should be and should not be taking leading up until surgery. If you read through it, I think it's fairly clear what we want you to be doing, but the highlights that I want to indicate for you here are that for the most part you can stay on your routine prescription medications right up until the day of surgery. The exception is going to be that anything that can thin your blood may need to be stopped ahead of time. If for some reason you have to stay on medications like aspirin or other blood thinners because you've been told that you have a medical condition that requires it, then it's okay for you to stay on those as long as that's what your physician has told you to do. Otherwise, please follow the instructions according to when you should stop that medication. If you notice the middle bullet point in the middle of the page, it talks about setting up a pre-anesthesia screening telephone conversation. That's an important part of the process that we have you do to make sure you're all set up for surgery from an anesthesia standpoint. You need to call the phone number and set up the appointment. The third page in the document right after this gives detailed instructions on how you do that. If you haven't already done that, please do that as soon as possible. Finally, I'll draw your attention to the final bullet point on that page, which discusses Kegel exercises or Kegel exercises. You're probably aware that one of the potential risks or side effects from prostate surgery is urinary incontinence or leaking. The reason you have leaking after the surgery is because the prostate is intimately involved in your urinary control. Obviously, the whole point of the surgery is to remove your prostate, and when it's taken out, you lose some of your natural ability to hold your urine. The good news is you have urinary control muscles which can do the job just fine without the prostate, but they won't be up to the task right away. If you start doing these exercises to strengthen and tone those muscles before surgery and afterwards, you will find that your urinary control recovery happens much smoother and quicker. Several pages farther on in the packet, a whole page is dedicated to the Kegel exercises. So please review that at your convenience and get started. Certainly if you have questions or difficulty doing the Kegel exercises or you're not sure you're isolating the right muscles, feel free to call us for more clarification. Okay, the next page we're going to focus on is titled Day Before Surgery. On the day before your surgery, we want you to complete a preoperative bowel prep. Basically what that means is when you wake up that morning, you're not going to eat any solid food all day. You'll be simply drinking thin liquids. I'm not going to go through point by point what you can and can't have because I think it's pretty clear on the page, but I just want to have that highlight that no solid foods that day. The second thing to remember is that around lunchtime, you need to drink one 10-ounce bottle of magnesium citrate. That's a laxative that will help evacuate the contents of your bowels and prepare you for surgery. It is fine to continue drinking liquids up until midnight the day before your surgery, but after midnight, please have nothing to drink. Another thing we want you to do the day before the surgery is in the afternoon, approximately 3 to 5 o'clock, give a call over to the hospital. There's bold type at the bottom of this page that gives you the number. Call the hospital. It's really important that you confirm the time of your surgery. They'll tell you what time your surgery is going to be and consequently what time you need to arrive at the hospital. Finally, don't forget, if your surgery is on a Monday, please make that phone call on Friday afternoon. Next, we're up to the day of surgery. You should take a shower the night before, so let me backtrack a little bit. Take a shower the night before and wash your body head to toe with an antibacterial soap. You don't need to buy any special surgery soap. It can be a traditional, typical antibacterial body soap. I know Dial and Safeguard both have products that would fit that requirement. So again, that's going to be the night before surgery and also the morning of surgery. The rest of that page has some kind of housekeeping issues that I think are pretty self-explanatory, but I do want to just highlight and reinforce one point. If you have diabetes and take diabetes medication, we want you to hold that medication, meaning do not take it the morning of surgery. That goes for both oral medications like metformin and also for injectable medication like insulin. All right, so we're skipping past the page now about Kegel exercises, which you can review on your own and get started. We're up to the next section, which is essentially a shopping list of items that you're going to need to have just before or after the surgery. And I'll go through them one by one with you. The first one says Depends male guards, and basically what that means is some kind of a absorbent pad product that you can use after the catheter comes out following surgery to help you with that urinary leaking that we talked about. You should know that all patients have different types of urinary leaking. Most of them have some degree of leaking when the catheter first comes out, but the amount can vary widely. Most people want to start with a pad that fits in the inside of the underwear to use for the leaking. Other patients are more comfortable with a pull-up type diaper style underwear that you can dispose of. Whatever works for you is okay with us. Some people are fine to get away with wearing one pad and it lasts all day long because they only have a little bit of leaking here or there. Other folks right away have a lot more leaking and they might require 4 or 5 pad changes in a day. The good news is that leaking gets better with everybody. It just takes some time for your brain, the nerves that control your bladder and the control muscles to kind of figure out how to do the job of urinary control without your prostate. To give you a rough estimate about how much leaking you'll have and how long it will last for, we find that about 50% of our patients are still wearing pads 2 months after the surgery. But that means about half of them are done wearing pads at 2 months, and they might have a little drop of leaking here or there, but it's not enough that they want to wear a pad in their underwear every day. Number 2 says brief type underwear, and the reason that's on the list is because those insert type pads that sit inside your underwear just tend to work much better with the jockey short type underwear as opposed to boxer shorts. Number 3 says KY jelly. That's a branded name, but really you could use a generic alternative. Basically, it's just a water-soluble lubricant, and you may want to use a product like that at the tip of the penis where the catheter comes out of your body. When you walk around and you're sitting up and getting in and out of a chair, the catheter can move around a little bit and irritate the tip of the penis. Obviously, that's a sensitive part of your body, and we find that if you put a drop of water-soluble lubricant right there, up to several times a day if you need to, that can really help with comfort. Number 4 is magnesium citrate. I mentioned that earlier in this speech. That's the product that you're going to take on the day before surgery for your bowel prep. You just need 1 bottle of magnesium citrate. Miralax is number 5. That's a product that's also used for your bowels, but we're going to have you take that after surgery for 2 weeks. When I talk about the diet and the bowels after surgery, I'll come back to that product, so we'll tell you a little bit more about how to use that, but just make sure you get a bottle of that at home to use after surgery. Finally, number 6 says loose-fitting pants. You want to take something with you to the hospital that's going to be comfortable to wear that you can cover up with. The nurses will get you to get up from your hospital bed even the same day of surgery and take a walk. So we get you up early to try to promote your recovery. Something like a pair of sweatpants or track pants, anything with an elastic waistband or a drawstring, tends to be fine for most folks. You'll be a little bit bloated and full, so a traditional pair of jeans or slacks may be too tight and uncomfortable for you. The next page we'll focus on is discussing discharge instructions. And the first heading talks about wound care. As it says, you are going to have 6 small incisions. 5 of them are on the smaller side and 1's a little bit larger. 4 of the 5 small incisions are going to be in a straight line right across your lower abdomen, so below your belly button, but just above where most guys wear their pants. On your left side, you'll have one a little bit higher than the belly button. That's the 5 small ones. They're all about 1 inch, maybe a little bit bigger than that. Right around the belly button area, you'll have the 6th incision, and that's the one that's a little bit larger. All those incisions are the way that the robotic instruments gain access into your body, and then the procedure can be done down in your pelvis. The prostate gets removed whole, along with the seminal vesicles, which are 2 small glands that sit behind the prostate. While it's still inside you, it's placed into a special bag that contains everything and keeps it isolated. When the surgery is complete, that larger incision that I told you about at your belly button is where the specimen comes up and out from. That tissue is then sent off to a pathologist who will do a careful review of the tissue and give us a report. The report will tell us a Gleason score, and it will also tell us some other information about the cancer, such as where it was inside your prostate, and if it was growing up to and involving the structure that surrounds your prostate called the capsule. It'll also tell us if there's any evidence of prostate cancer outside the prostate, in those neighboring seminal vesicles I discussed, or in any pelvic lymph nodes that the doctor may or may not resect at the time of your surgery. All those incisions are going to be closed up with absorbable stitches and then covered over with the surgical skin glue. So you won't have any stitches that you need to have removed by our office. The surgical skin glue is nice because it keeps the edges of your incision, the skin edges, close together and lets the skin heal underneath. It also protects them and keeps them clean. It makes it really easy for you to care for your incisions afterward. There's very little that you have to do except just be careful, really. You don't have to put any creams or ointments on them. In fact, we ask you to please not do that. And there's no bandages or dressings to change. Probably one of the nicest parts about that skin glue is it allows you to get wet even the next day when you go home, so taking a shower is okay. You want to avoid a bath for the first week when you have the catheter in, but certainly taking a shower and having the incisions get wet briefly while you carefully wash and rinse them is fine to do. Because you have these 6 small incisions, you will be fair game to have some swelling and bruising. It's variable across patients how much swelling or bruising you may have. Some patients have a very minor amount and some have a lot. The swelling may make you feel bloated or full, and as I said before, may make your pants feel or fit more tightly than you're used to. When you look down at your abdomen, you may see the evidence of the bruising. So that will look like black and blue kind of traditional bruising. You may see a little bit around each incision, or again, you may be someone who has a lot of bruising, and it could look like one large swath of bruising across your midsection. Don't be alarmed if you see that. It doesn't necessarily mean anything went wrong. That is a normal response. I do want to let you know, because some people are shocked by it, that if you are one of the folks who has a lot of swelling and bruising, because of gravity, that fluid will make its way down. So it'll end up collecting in your pelvis. And that may manifest as if you look down, seeing the penis itself getting swollen looking or puffy, and it can have black and blue discoloration, and the same thing goes for the scrotum. I mention that because in some cases it can be relatively remarkable swelling, and your scrotum can get as large as a grapefruit or a softball and can be black and blue and really look discolored. Don't be alarmed if you see that. There are a few more notes there about the surgical glue and how they might feel, which I'll let you read. Again, if you ever have questions, it's fine to give us a call. The second section on this discharge instruction sheet details the activity restrictions that we ask of you. This is a very important section as we really want you to heal appropriately and not have any post-operative complications. Doing too much too soon can prevent you from healing the right way and can cause bleeding, hernias, or other problems. The basic idea is that for 4 full weeks you need to really take it easy with activity. 15 pounds is the limit for what you can lift, and we ask you to not do really anything more strenuous than walking. So that means no golf, no tennis, jogging, no swimming for exercise, going to the gym, or working out in the yard. Walking, on the other hand, is encouraged, and we want you to do walking every day. We don't restrict you in terms of how much you walk. We just ask you to let your body kind of dictate how much you do. So if you're feeling too tired or too sore, let that be an indicator to slow down and stop. We think you'll probably be feeling better every day and be up for doing a little bit more physically every day. The final section of this discharge instruction sheet talks about driving restrictions. Most people are interested to know when they can drive again, which is a reasonable question. The good news is most people feel pretty good relatively quickly after this surgery. We think it's okay to start driving again when you feel safe to do it. The one real restriction that says you can't drive is if you're taking any of the narcotic pain medication that you'll be prescribed after the surgery. If you are taking those, you're not allowed to drive. The good news is most folks, if they take that at all, usually only end up needing it for a couple of days. To give you a realistic expectation, it's probably average that most people start driving 7 to 10 days after surgery. But again, as long as you're not taking the pain medication and you feel safe to drive, you're good to resume driving. All right, let's move on to the next page. The top of the next page is entitled Pain. Fortunately, most folks with this surgery don't have excruciating pain postoperatively. It's usually described as a moderate amount of discomfort. Certainly not described as much pain as, say, a orthopedic surgery like a shoulder replacement or a knee surgery. Most people describe the discomfort as mostly being isolated to the abdomen. Where the incisions go through your stomach muscles can cause some muscular soreness. Some people have described it as a feeling of soreness as if you did 100 sit-ups or crunches. Fortunately, there's usually not too much pain down low in the pelvis where the prostate was. If there is any discomfort there, it's typically in the perineum, or the part of your body where a bicycle seat would hit. So maybe if you're sitting on a hard chair, you might have some tenderness and want to have a cushion. For pain control, we recommend first trying plain Tylenol all by itself. If you just have mild discomfort, try taking Tylenol. If you feel like that controls your pain adequately, you don't have to do anything else. If you feel like you need something stronger and Tylenol is not quite taking the edge off enough, you will be given a prescription for a narcotic pain medication, and it's fine to use that. I will tell you that those medications are pretty notorious for causing constipation, and they can make it harder for you to move your bowels post-operatively. So I caution you to try to use the least amount of that pain medication as you think you need. As a guideline to give you some expectation, probably an average amount of the painkiller that people use is maybe 4 to 6 tablets, and usually they're done using them by day 3 or day 4 post-operatively. That leads right into some additional discussion on medication. The 2 new prescriptions that you're going to have when you leave the hospital are 1 for the narcotic pain medication I just talked about, and number 2 for an antibiotic. Unlike the pain medication, which you only have to take if you want to, the antibiotic we ask you to take every day as directed until it's gone. The 3rd medication that you're going to be taking afterward that's new is not a prescription, it's an over-the-counter medication to help you move your bowels, and that's Miralax. Recall I did mention that earlier, it's on your shopping list. That's a powder-based laxative, and we want you to take it once a day after surgery, for the first 2 weeks at least. The thought process is that after surgery, for a number of reasons, your bowels don't start working right away again. And most people don't have their first bowel movement after surgery for 3, 4, or even maybe 5 days. So the Miralax will help to kickstart that function to get it back online. So once you have your first bowel movement, it'll also help to keep your stools loose. For the same reason we don't want you straining at sports or yard work, we don't want you straining to move your bowels either. So we want the stools to stay soft after surgery, and this Miralax is going to help you achieve that. A goal that we say to shoot for is to try to keep the stools soft like a toothpaste consistency. So start with 1 dose of Miralax every day, and then see how you do. If you find that that's too much for you, and that would be evidenced by maybe having too frequent bowel movements or the stools would be too soft or loose like water, then it's okay to cut back on the Miralax. You can start with a half a dose every day, or you can go to using it every other day. But the important thing is for at least those first 2 weeks, be using that on some regular level to keep the stools soft. All right, the bottom half of the current page that we're on deals some more with the diet and bowels. Because you may not be having your first bowel movement for several days after surgery, you're going to want to take it easy with what you're eating. So that means small portion sizes, and try to avoid things that you know historically are difficult for you to digest. As soon as you start passing gas and moving your bowels, you'll find that you're able to pretty quickly advance your diet back to what you're accustomed to eating normally. As I said, it can be 3, 4, or even 5 days after surgery for your first bowel movement, and that's normal and okay. If you get beyond 5 days, meaning if you get to the morning of the 6th day after surgery and you haven't had a bowel movement yet, then we want you to do something a little bit more aggressive than the standard regimen. So again, the standard regimen is taking a dose of Miralax every day, so you should be doing that. Drinking a lot of water helps to get the bowels moving, and being up and walking around helps. If you're doing all those things and you get to the 6th morning and you haven't had a bowel movement, we ask you to take a little bit more of an aggressive medication. And that's indicated at the bottom of that page. It's called milk of magnesia. So take 1 dose if you need to. Most people don't need to get to the point where they do that because their bowels start moving in those first couple of days. All right, we're on to the next page in the section regarding catheter care. Don't feel unique if you have some anxiety regarding the catheter. That's normal, and most people are a little bit concerned about it. We'll get you through it just fine though, and you'll do okay, I'm sure. Again, we're always available if you have questions with the catheter as they come up. To try to give you some comfort about what to expect, I'm going to review some of the materials that you'll have in brief. The catheter itself is a flexible rubber tube that looks like this. It's going to be put inside you when you're asleep in surgery, and when you wake up it'll already be done. But to give you a sense of what happens is, the tip of the catheter goes in, imagine this is the penis, into the tip of the penis, and it's fed all the way up until it gets inside your bladder. So you could imagine the bladder's up here. It's held in place by a small balloon on the end of the catheter, which we can inflate and deflate through this plastic port on the outside. So I'll demonstrate that. I'll pump the balloon up. That small balloon on the inside of your bladder is what prevents it from falling out inadvertently. So as we draw back, it sits right at the neck of the bladder and the catheter won't come out of you. So you'll have probably this much of the catheter visible coming out of the tip of the penis. The 2 pieces on the end that you'll see, again, the hard plastic piece is for us to inflate and deflate the balloon, and you can disregard that. You won't need to do anything with that part. You'll be dealing with the hollow tube at the end where the urine comes out from. When you first wake up from surgery, the catheter is going to be connected to a bag that looks just like this to collect the urine. This is a large bag. It holds a lot of urine, and you'll be able to use that as you're walking around in the hospital. So again, the nurses will get you to get up and walk the hospital. You can hold this bag in your hand when you're walking, or if you want to clip it inside your gown pocket or your pants pocket, that's fine too. When you go home, you'll have this bag at first as well. And again, the same thing. When you're walking, you'll hold it in your hand. When you sit down, you can just place the bag right down on the floor next to where you end up sitting. You'll find that as it fills up, it gets pretty heavy, so you'll want to empty it every couple of hours. To empty it, there's a small device at the bottom here that's pretty straightforward. You can review it with your nurse in the hospital before you leave, but the basic idea is you'll release these green plastic tabs, just like that. You'll aim it into the toilet, and there's a small silver clamp here at the bottom that you release with your thumb, and that'll allow the urine to flow out. When the bag's empty, you clip that silver clamp again and place the green clip back in the holster. You're actually going to be sent home with 2 different types of collection bags. This is the first one, and it's sometimes called an overnight bag or a hospital bag. If you want to use this exclusively while you're at home, that's fine. The other bag just presents another option that I'll review why you might want to use it. But of the 2 bags, certainly this is the one you want to be using overnight. The reason being is it has a larger capacity, and you won't have to get up out of bed and drain the bag in the middle of the night. It can sometimes be a little bit challenging to figure out what you do with all the bag and the tubing in the night, but a couple things to keep in mind is, number 1, the urine is draining from your bladder by gravity alone. So the bag here needs to stay at the same level of your bladder or lower down. So when you're in bed, this could either be sitting in bed with you, but ideally you'd get it over the edge of the bed and down a little ways. There are clips on the back of the bag that may be able to clip onto a side railing on your bed. If it doesn't accommodate the clips, then a trick you can use is taking a traditional clothes hanger, putting it flat in between your mattress and box spring with just the hook hanging out a little way, and then you can hang this hook right on the side there. I should briefly show you how it connects and disconnects. The end of the tubing of the bag is a tapered piece of plastic, and it simply pushes directly into the rubber catheter. You simply press hard like that, and the friction will keep it in place. There's no other clamping device needed. If you decide you'd like to use the other bag, I'll show you how to do that. So to remove it, you pinch it here like that, grab the plastic tubing, and you're going to just pull it out. Sometimes it's really stuck in there strong, and as you pull, you need to use your thumb to push that rubber catheter back as you pull out. And you work it around the outside, and it pops right off. Because a small amount of urine may be dripping out of here as you make the switch, you can either squeeze it tight with your thumb and forefinger, or better yet, probably do the change in the shower or over the toilet. So the second bag that we're going to give you looks like this. It's much smaller, and it doesn't have this long intermediate clear plastic tubing. So it connects directly from the catheter right to the bag, just like this. This is called a leg bag, and because it attaches to your leg. There's a strap here. This goes around your upper leg. The lower strap should go around your lower thigh, but still above your knee. The nice part about this bag is you can pull a pair of shorts or pants over top of it, and you don't have to hold it when you're walking. So it's hands-free, number one, but also it provides a discreet option. So if you're walking around the block or your neighborhood, or if you're having visitors coming over to see you and you don't want to explain the catheter, that's a nice option. To empty this bag, there's a small valve at the bottom with a flap. So you take this blue tab, you pull it down like that, that opens the valve and the urine will come out. When you're done, make sure you close it back down. That's the leg bag. When you come back in to see us 1 week after the surgery, that's when the catheter will be removed. On that day, we'll be able to deflate this balloon from the outside, just like that. And that allows the catheter to come out of you very easily. There are several other notes about the catheter on our handout, so you can review those bullet points, which I think are pretty self-explanatory as well. One thing I want to draw your attention to is the possibility of seeing blood in the urine. The top of both of these bags is made of transparent plastic, so you'll be able to see what the urine looks like inside. Don't be alarmed if you see blood. Normally, the urine stays pretty normal, kind of a clear yellow color after the surgery, but it's not uncommon to see blood on and off. And it may even happen several days after the surgery. That's not an indicator that anything went wrong necessarily. The reason that can happen is the catheter goes right through your urethra, your urinary tube, and right through the section where your prostate used to be, where your urinary tube has been stitched back together. So you have some stitches there. Where the catheter rubs, it could cause a little bit of bleeding. It doesn't take a lot of drops of red blood in a bag of urine this size to make it look pretty red. So if you see some flakes of blood in otherwise clear urine, if you see a pink tinge to the urine uniformly, or even if you see the entirety look red like fruit punch or cranberry juice, that's not reason to panic. That can be normal occurrences after surgery. Usually it gets really red like that. It's after you've done something physical, like went for a walk, or maybe had a bowel movement. That can stimulate some bleeding. If you take it easy after that, sit down on the couch maybe, rest for a little bit, and drink some extra fluids, you'll find that the urine clears up pretty quickly. Certainly if you have persistent bleeding that's not stopping, you need to let us know. On the final page, beneath the catheter section, is a section entitled When to Call Us. All these bullet points are things that are uncommon and unexpected, so you should be on the lookout for any of these things occurring. And if they happen, please call us. As I've said a few times, I think most of them are relatively self-explanatory and mostly common sense things, but I'll briefly run through them. It is normal to have an elevated temperature after surgery, what some people call a low-grade fever. So even up to 100.5 degrees would be considered normal and okay. Typically, you'll find that if you take a Tylenol with a low-grade fever, it'll come down. If you have a persistent fever that's getting above 101, however, even after taking Tylenol, it's above 101, or it's accompanied by shaking chills, that would be abnormal and you'd want to call us right away. I mentioned that you could have pain. Certainly discomfort is not uncommon, but it should be well controlled with your pain medication. If you're having severe pain that's not controlled, even with medication, you need to tell us. If any of your incisions look red, split open, start bleeding, or have any other pus or discharge coming out of them, that would be another abnormal finding that you'd want to tell us about. I said it would be not uncommon to see traces of blood in the urine, even sometimes red in urine like fruit punch. But if the urine is looking more like ketchup, it's thick and it looks like straight blood, or you're seeing very large clots in there, particularly if any of them seem like they're obstructing the flow of urine out of your catheter, those would be not expected and we want you to tell us about that. One finding that might not be common sense to some people if you're not in the medical field is that if you get swelling in your lower leg, the calf muscle area, cramping sensation or discomfort there, you might think it's unrelated, and it may be, but it may be the sign of a blood clot, which we take very seriously. So if you get single-sided leg cramping, behind your knee, pain, swelling, or a discoloration of the skin, or a warmth or coolness to the skin that's abnormal, please tell us about that right away as well. Finally, some people have some nausea with the anesthesia medicine from surgery or from the pain medicine after surgery. So having some nausea and maybe even vomiting one time may not be a concerning finding, but if you're having persistent vomiting, that's not normal, and you need to tell us about that. The final section talks about and details the appointments that we'll have for you after surgery. I've already mentioned it once at least, but you'll have your catheter removed 1 week after surgery. At that appointment, you'll also have a chance to review your surgical pathology report if it's back from the pathologist, and it usually is. Other checkups include a 1-month checkup. Typically that's with a physician assistant such as myself on a day your surgeon's in the office. And then 3 months after surgery is when you'll usually first see your surgeon on his schedule alone, and that's typically the time we get your first PSA after surgery. Certainly if you have any other things that come up along the way, we can see you more frequently than that, but that's just the standard schedule. So that concludes the formal information that I wanted to present to you today. Please remember that what we spoke about today is simply highlighting some of the important facts that are contained in your information packet. You should review that on several occasions before and leading up to the surgery. If you have questions after the surgery, review back to that packet as it may have the answer to your questions. Again, if you have a question and it's not answered in there, we're available anytime to answer your questions. We look forward to taking care of you, and have a great day.